Hi, and welcome to Unit 11, where we're going to talk about human immunodeficiency virus and acquired immunodeficiency syndrome, HIV and AIDS. There are about 36 million people in the world that have AIDS. It's the leading cause of death in Africa and the fourth leading cause of death worldwide. About 2 million people die every year because of AIDS or complications related to AIDS. According to the CDC, there are 1.2 million people living in the United States with AIDS. The new name for the virus is human immunodeficiency virus, or HIV, and that was first named HIV in 1987. In 1987, the new name was recognized by an international commission, and the old names were HTLV3 and lymphadenopathy-associated virus. It was changed to HIV by this international commission in 1987. HTLV3 was human T-cell lymphotrophic virus 3. This virus, now known as HIV, attacks the T helper cells, and there's about a 5 to 15 year incubation period. There are two strains, the HIV-1 strain and the HIV-2 strain. The HIV-1 strain is what causes the main epidemic, and there's three groups known as M, O, and N, and there are 5 subtypes of the HIV-2 strain, which is mostly seen in West Africa. It's less virulent than HIV-1. The HIV virus can be isolated in blood and semen and breast milk. The highest concentration of the virus is noted in semen. It can be transmitted by blood products, dirty needles, semen and vaginal secretions. It can go from mother to child and can be associated with tissue transplants. It is not transmitted by casual contact. There is no evidence that it can be transmitted from saliva or tears, but HIV has been identified in the saliva and tears of patients that have HIV. There's no evidence of mosquito transmission and no evidence that it can be transmitted by the hepatitis B virus hepatitis B vaccine that is made from human plasma. There are specific populations at risk for infection with HIV, and that would include people with multiple sexual partners, people that are intravenous drug users or they share needles, patients receiving multiple blood transfusions, and that would be blood or blood products, but they are tested for the virus, patients that are hemophiliacs and are being treated with factor VIII, infants born to mothers in the above groups, and finally healthcare workers. These are all populations that are more at risk for developing an HIV infection. Patients with HIV and AIDS usually develop several opportunistic infections over the course of the disease, and they usually succumb to one of these opportunistic infections. They can develop bacterial infections such as Mycobacterium avium intracellular. They can develop fungal infections such as Cryptococcus, Candidiasis, and histoplasmosis. They can develop protozoan infections such as Cryptosporidium, pneumocystis, or toxoplasmosis. They can catch viral infections such as herpes simplex complex or cytomegalovirus. And then also they can develop neoplasms, which are a new or an abnormal formation of a tissue or a tumor. And one such neoplasm that is common in AIDS patients is Kaposi sarcoma. But they can also develop CNS and peripheral organ lymphoma as well. AIDS results in a permanent dysfunction of the host cellular immune response. Their T helper cells are what are infected, and that's part of the CD4 group. They have lymphopenia, which is pronounced, and then their T4 and T8 ratios are inverted. Usually your CD4 group should have about 65% in the circulating blood, and you're going to see that absolutely inverted in people with AIDS compared to the CD8 cells. People that have AIDS have hypergammaglobulinemia, and they also have the presence of immune complexes in their tissues, kidneys, and lungs. There are several cells that are especially susceptible to HIV. That would be the hematopoietic cells, which are your T helper, B cells, and stem cells. Your brain cells, which include the capillary endothelial cells and the astrocytes. We have the gastrointestinal cells, which are the colon carcinoma cells, columnar and epithelial cells, or stromal macrophages and lymphocytes. We have skin cells like Langerhans cells and fibroblasts, and then miscellaneous cells that are affected like Kupffer cells of the liver and osteosarcoma cells. Let's take a look at the life cycle of the virus itself. So the HIV virus binds to a cell and fuses to it. The particle used to bind to the cell is designated glycoprotein 120. The receptor on the cell surface of our T helper cells is called the CD4 receptor. T cells and some B cells are too susceptible to HIV. The viral membrane fuses to the cell membrane and ingests its core material into the cell. The core material of the virus includes RNA and reverse transcriptase enzyme. Other factors in core material are core proteins such as P24, P17, P9, and P7. The viral RNA is then converted by reverse transcriptase into DNA. DNA is then integrated into the DNA of the target cell. This migrates to the cell's nucleus. Viral DNA is transcribed into viral messenger RNA, and new virus particles are created and infect other cells, and then finally the CD4 cells are destroyed. Healthy individuals usually have about 65% of CD4 cells and about 35% of CD8 cells. The CD4 cells, of course, are your T helper cells and your T delayed type hypersensitivity cells, while an individual with AIDS has CD4 and CD8 ratios that are inverted. So their CD4 cells, their T helper cells, and T delayed type hypersensitivity cells are about 35%, and their CD8 cells, which includes T cytotoxic and T suppressor cells, are going to be 65%. A T helper cell count that is common in a normal person that does not have HIV or AIDS is about 800 times 10 to the 9th, and that's approximately 8 billion or so per millimeter cubed. HIV is a type of retrovirus. It is called a retrovirus because it doesn't convert DNA to RNA, but vice versa. It contains a single strand of RNA, and it contains the enzyme reverse transcriptase. The core proteins of this retrovirus are P24, P17, P9, P7, and P25, while the envelope proteins, and these are pretty important proteins, are glycoprotein 120 and glycoprotein 41. These are envelope proteins that are outside the outer membrane and interact with target cells. Here's a nice diagram of the three major protein groups of serological importance. We have the GAG proteins, which are group-specific proteins. We have the POL proteins, which are polymerase proteins. And we have the envelope proteins that are located within and outside of the outer membrane. They actually interact with the target cells. There are three stages of the AIDS virus. We've got the acute stage, the asymptomatic phase, and advanced HIV disease. In the acute stage of the disease, usually our patient is asymptomatic. They may have a low-grade fever, malaise, and a rash as the patient starts to seroconvert. The antigen is detectable in the blood and CD4 counts are depressed. As antibodies start to appear, symptoms may abate and the antigen may be undetectable. We can further divide this second stage into the asymptomatic stage, that is a late asymptomatic stage, and an early asymptomatic stage. In the early asymptomatic stage of the disease, our lymph nodes start to enlarge. Biopsies show clusters of CD8 cells. The T suppressor cells are especially increased. The ratio of CD4 and CD8 cells is starting to get reversed, and our patients may show hypergammaglobulinemia or B cell function problems. In the late asymptomatic stage, there's a steady decline in the CD4 cells. IgA is starting to elevate, interferon levels are increased, and this stage lasts for about 18 months. In advanced HIV disease, our CD4 cell count really starts to decrease. It's usually below 200 or 100 millimeters cubed, okay? They're starting to have clinical evidence of the disease at this stage, such as opportunistic infections, weight loss, and fevers. They can have total absence of delayed hypersensitivity, have severe viral or fungal infections. Here it is defined as AIDS and not HIV. And usually their opportunistic infections have started to explode here. There are much better therapies and drugs for AIDS patients now than there were 10 years ago. There are a number of antiretroviral drugs available on the market today. One such group is called the nucleoside reverse transcriptase inhibitors. Those block HIV's ability to infect other CD4 cells, and they block reverse transcriptase enzyme. One of the first NRTIs that you may have heard of is called AZT, which is zidovudine. A non-nucleoside reverse transcriptase inhibitor is another type of drug that inhibits the function of reverse transcriptase. Drugs are efavirenz and nevirapine. The protein inhibitors blocks HIV enzyme protease, and the virus then cannot copy itself. We've got fusion inhibitors that block HIV from entering the CD4 cells. And we've got entry inhibitors like CCR5 antagonists, which blocks the protein that are required to enter the CD4 cells. And then finally, we have integrase strand transfer inhibitor, which blocks the enzyme integrase and prevents HIV DNA from entering the human DNA. There are a number of ways that HIV can be noted in the laboratory. One is by looking for the core antigen, where we have viral replication that is increased and the appearance of core antigen is apparent. We can look for antibodies to HIV. After about 6 to 12 weeks of seroconversion, we can look for antibodies to glycoprotein 41 and protein 24. We can use PCR, which is DNA amplification of the active virus. We can use Western blot, which is a confirmatory test by looking for HIV proteins electrophoretically, and we look for proteins P24, GP41, GP120, and GP160. We can do quantitative RNA tests, rapid tests, including sensitive Alere HIV 1 and 2 combo tests, or HIV stat pack, multi-spot HIV 1 and HIV 2 tests. Those usually are okay for accidental exposures, but they have a low sensitivity.